Today we have the pleasure of Gary Bain here to talk to us about compression therapy and all things related to lower leg edema and wound care. We're really lucky to have Gary here, who has a world of experience in this area. And we know that edema is often misunderstood or not well understood amongst our community of allied health professionals. And we often just don't know how to identify or diagnose and what the management plan or referral pathways are. So let's debunk some of these truths and myths of lower leg edema today. And I'm going to pick Gary's brains on everything he knows on this topic. Now, Gary is the wound guy, and as a collaborator with the Wound Educator, we are here to improve the wound literacy of our community and colleagues and minimize harm caused by wounds. So over to you, Gary. First question, can you tell us a bit about your background and experience in terms of wound care and chronic wounds?
Yeah, thank you, Lucy. My journey and interest in wounds started a long time ago. It was working in an operating theatre as an instrument technician. I got to work with plastic surgeons and saw the amazing things they did in putting people back together after major trauma. That sparked into my head a little interest in wounds that wasn't then to really come out and start to flourish from about 1987 onwards. And then all of the years between now and then, I've had the privilege of doing things like running leg ulcer clinics, working with all forms of surgeons, working with community nurses, those in general practice and aged care. So I've had a pretty broad exposure to the kind of wounds that we are getting now used to seeing as problematic or chronic, certainly expensive and debilitating out in our community. I presently work as part of a rehabilitation hospital. And for me, as I'm nearing the end of my professional career, I couldn't have landed in a better place because I'm seeing really almost the amalgamation of all my wound experiences over the decades come together in the one place where I'm seeing people with lymphedema in one unit, people with spinal cord and brain injury in another, orthopedic in another, folks who've gone on to have plastic surgery, those who've been involved in major trauma, all kind of things over the years have now coalesced to be at the one kind of place where I am now. And I get my hands dirty there. I get to smell it and see it and feel all these things, but also mainly get time to teach our doctors, nurses, and allied health so that at some point I can hand over and say, these guys, this is now something you can learn, you can do and take it so much further and be better than I've ever been. But it just allows us to then say, okay, here is somebody with a wound, but it's never to talk about the wound. It is always somebody with a wound. So how does a wound impact that person? And how does it destroy or alter or in some way compromise their quality of life? And to me, that's our reason to exist. A wound is something that may be healable, hard to heal, or even non-healing. But at the end of each and every day, how have we made that person's well-being the best it possibly can be, knowing with what we've got to deal with before us? So that is my mission now, really, is to allow people with wounds to have a degree of dignity and quality to life.
Yeah, great. It's also spreading your knowledge and getting other people around you to be able to do what you do, but sometimes even more than what we can do on our own, isn't it?
Yes.
Yeah.
Yeah.
So now, great. Can you explain to our audience what is lower leg edema? And do you have an analogy you can use to help us understand it?
Yes, yeah. Well, it's interesting when we talk about lower limb edema, most people focus on the fact that it is the accumulation of fluid. And you often hear the non-health professionals saying, oh, look, I have fluid in my legs, I have fluid in my arms, fluid in my fingers, all of this. So we concentrate on the idea that it seems to be a fluid burden to skin. And there is certainly there is a huge water or fluid component to it. But really there's a very big cellular component to it as well. So you'll often hear many lymphedema therapists talk about the collection of fluid within limbs and talk about it being a protein-rich fluid. Um, in a way, I think what we've needed to do to understand edema better is to ultimately par it back to say, well, how does the flow of fluid through skin normally happen? And we've got our three layers to skin, the epidermis, dermis, and the adipose. And we know about 15% of the integumentary system's water is in the epidermis. So it means 85% of your skin's water is in that dermal and the adipose layer. I like to think of that dermis and the adipose layer as being like a bath. It's always meant to be 85% full of fluid. And that's then how your integument works best, when that's about the right fluid level. What happens is you get fluid moving from your bloodstream coming through the little capillary loops in that dermal layer of skin. So there is where your oxygenation, your nutrition, all of your solutes come out of the capillary loop about 1 millimeter into your skin, and then that provides nourishment to what is really now that bath layer. And then as that fluid moves through the bath layer, it picks up a lot of waste. So this is that cellular debris that I referred to earlier. So with that is that cellular debris as well as wastewater that needs to leave the integument, needs to leave the skin bath, and then it needs to go away. And it happens that it all drains away in the lymph system. So really the lymph system, for me in my head, I compare that to being the plug hole, whereas the nutrients coming from the plasma are really the tap. So a really healthy integument is where you've got your integumentary bath, and at one end is nutrients coming in from the tap, waste going out down the plug hole. And as long as what comes into the bath is the same rate at what goes out of the bath, you have a very healthy integument, always being filled with nutrient, always removing waste, but never demonstrating any edema. If something goes wrong with the bath, then edema may become apparent. And that can either happen by the tap running faster than the plug hole can keep up with, or it may be that there's a plug hole problem itself, and it doesn't matter how fast or slow the tap runs, ultimately the bath overflows if the drain pipe can't take the water away. So the bath I very much use around the whole idea of edema is, how is your integumentary system bath going? And as long as your input equals your output, then you don't have edema. But you can have the tap or the plug hole being an issue, and then edema does arrive. So I think when it comes to trying to figure out why is edema present, I ultimately say to clinicians and to patients, ask your GP, ask your lymphedema therapist, ask your specialist. If you've got swelling, is your swelling there because it's a tap problem or a plug problem or a combination of the two?
Yeah, that's a great analogy, the bath analogy. And I know you've got a great video, A Simple Guide to Edema.
Yeah, a little animation that helps.
Yes,
Yeah,
I'll be certainly sharing that through in this webinar as well as part of the resources.
lovely.
Now, I know there's different types of edema, and sometimes patients or doctors don't really know whether this is a venous edema or whether it's coming from somewhere else, like the heart or another organ.
Mm.
And how do we explain to the patient or help doctors and pharmacists, nurses understand what type of edema where this patient is actually?
Yeah. And this is such an important thing to be able to try and figure out, and to be very honest with you, really to make the diagnosis, to explain that to an Uncle Reg. Say Uncle Reg is the patient. I would say, Uncle Reg, your wound is there because of a particular reason. It's all the same thing, the same thought. Uncle Reg, your swelling to your leg is there because of. And so this requires a diagnosis, and really in many respects, this is a medically directed thing, is to be able to say your lymphedema is there because of a particular reason. Because we are aware that there are a multitude. In fact, there'll be a slide that you'll be able to show a bit later on where there's listed 20 etiologies as to when you can have a tap or a plug problem. Some of these will be heart related, some of them will be medication related, some of them will be malnutrition related. One of the big deals is to figure out, is the lymphedema a problem because there's an absence of drainage holes or plug holes. And this is related to primary lymphedema, where it's a congenital thing quite often, where people are born with an absence or adequate supply of lymph vessels. So primary lymphedema needs to be seen as, hey, is that an issue? Is this actually something that you were born with or that develops after your teenage years or after pregnancy? Is there an insufficiency in the piping itself? When it comes to secondary forms of edema, then these are the ones that we most commonly see in community practice. It's interesting the number of secondary edema issues which are actually side effects of the medications that people take.
Yeah.
So when we talk about people being put on to antihypertensives, for instance, in Australia in 2023, antihypertensives were the third and fourth most commonly prescribed drugs in 2023, and yet they have some profound side effects which cause lower limb edema, as do proton pump inhibitors, and statins may actually make people's muscle pumping and utilization awkward if they get myalgia, and so that may incur edema. So medications are a big factor in this. Aspects like heart failure, if you get right-sided heart failure, the pump can't drain the fluid away from the lower limb. It puts back pressure on the venous system, so it all goes back down to the lower limb. So right-sided heart failure, we see the puffing up of lower limbs. So that is a big issue. If there's renal problems there, once more, you're not being able to filter and take fluid out of the vascular system. You're not expelling it through the bladder. So look, there's so many potential organ issues. There are therapeutic issues around, we know radiation, for instance, destroys some of your lymphatic component. So it becomes much harder to get pipe drainage when you've got sclerosed tissue as a result of radiation. So when you look at that list of 20 possible things that could go wrong, you realize we actually do need great diagnostic support to figure out what's going on. You know, in the whole world population, one of the greatest causes of lower limb swelling is in fact a parasitic infection called filariasis. And to diagnose that is something that in Australia we'll see little of unless you're up in our tropical areas. So if you're in the Northern Territory and Northern Queensland, this might be an issue that you begin to see. But once more, it's actually like the Woundiverse concept. It is, who do you need on your team who's got that skill set that can help you look at the patient in their entirety to figure out there are so many reasons why the bath can be impacted with the tap running too fast, the plug draining too slow. Which of these issues is it, or is it both? So we need to now look at saying, is there an endemic infection you've been exposed to? Is there medication you're on? Is there organ failure in other parts of the body which impacts on the integument? So it's a really big global view. So it's like I tell people with wounds, look beyond the wound, start to look bigger. In fact, forget the wound and go back to really appreciate who the entire person is. I'd almost say the same with edema as well. So many causes, so many reasons for it to be there. And the only way we're really going to begin to find out what's happening is to come all the way back up to look at the person themselves. Who are they? What is their story? What is their medical conditions? What are their medications? And then we begin to see clues. And in fact, I got a little thing to tell you, Lucy. It came from a GP who I'm very, very fond of, who's now retired. He said this, he said that with any medical diagnosis that's required, 90% of finding a diagnosis is found in the patient's story. In other words, a really good history. 9% of getting to a diagnosis is whatever physical examination you do. So it's hands, eyes, nose, ears. And then 1% of finding a diagnosis is in the tests or the investigations that are conducted. So 90% is in the story, 9% is in your physical examination, 1% in your investigations. And when I consider that that is the pathway to a diagnosis, I now begin to see where my role might be in this Woundiverse approach to saying, what can I do? What can I help? What can I understand? And from a community pharmacist point of view, one of the greatest tools you'll ever be able to develop is a strategy or a way of proceeding to encapsulate what a good story is. what can that patient tell you about who they are, their circumstances, how they live, where they've been, how this has developed, over what time it's developed, how it compromises them, what medications are on, what things they get treated for. There is so much in the story, and that's often where the time investment is. Getting a really good history is the longest part of any consultation, but there is where 90% of your clues are. So I like that way of thinking, that model, 90%, 9%, 1%. Yeah, that kind of helps me have a bit of an understanding as to what I can do and then what I need others to help with.
Yeah. So the first step is actually to talk to the patient and find out their story and kind
Yeah,
of profile this whole person rather than jumping straight
absolutely.
to
And, you
pathology.
know, then it becomes a bit challenging because not everybody is a good historian or has a good memory. And then we get to people who may have various language challenges or educational, cultural challenges as well. And sometimes these are the very real, everyday social instances that come along just to make actually proceeding to care for somebody difficult if we actually can't get a good story in the first instance.
Yeah. Sometimes just asking them the question or inviting them to a consult room in a private space, and they will just open up and tell you their whole life story. So I find
Yeah,
that very effective when I'm
that can be useful. So and then sometimes you need to guide and direct them because you then get too much information that's maybe not on point. But yeah,
yeah,
the clues are in the story for sure.
yeah, wonderful. So with venous edema, can you tell us a bit about how that works with when the veins are malfunctioning and what are the symptoms of a
Oh,
venous
man.
edema?
There's something that Schuback and colleagues recently released, so just really only a month ago, but it's called congestive lower extremity failure. And we were fortunate to do a LinkedIn post on that and a Facebook post on the Wound Guy recently about that. But this is the latest model for talking about your very question, Lucy, which we call Fleblo lymphedema. In other words, the vein side, because it's the single most common form within our society anyway. It's ultimately because we're all impacted by gravity and largely driven by the fact that we have valves within our veins and in our lymphatics. And because we tend to be upright beings, either sitting or standing a lot of the time, we find that around the gaiter area of the lower limb, it tends to become the higher point of pressure for the leg. And one of the ways in which you try and minimize pressure for the lower limb is to have motion or mobility or calf muscle pumping. And as you do that, it's designed to take fluid from both the veins and the lymphatics away from the lower limb, and then take the pressures and those two sets of vessels down. So your veins and lymphatics are meant to be their most healthy when their pressures are lowest. But as we go through life and some of the things that we experience, as well as just a sheer length of years and gravity, one of the major things that happens is that we gradually lose valve functioning. And when that happens, you start to then find that rather than having fluid always moving up the leg, you tend to find fluid moves up the leg with a calf muscle pump function or with an inspiration, but when you breathe out or your calf muscle's not contracting, then fluid goes back down if the valve doesn't work. One of the most important things that damages your lymphatics and your veins is this up of fluid when you breathe in and when you have a muscle movement, or when you breathe out and the muscle movement stops and it comes down again, this up and down, the up and the down. That causes this tremendous water hammering effect, which actually damages the inside lining of our veins and our lymphatics. And then a buildup of pressure with that then means the inside lining is fractured, but the wall of the veins, the wall of the lymphatics starts to become distended with pressure. And as that happens, they then start to leak. And when they leak, they are leaking fluid, which is from within the blood vessel itself, and that is largely plasma. So this fluid's moving now, not staying in the skin, in the vascular space, coming into the skin space, but then with that is also all of this cellular material as well, which is ultimately what brings you to these pigmentation changes we see with these lower limbs. Also, the changes to the character of skin. It becomes very hardened and indurated and woody, leathery like, which we call lipodermatosclerosis. So these pigmentation and these the changes to the texture of skin all happens because of abnormal cell movement out of the vascular system into the integumentary system or integumentary structures. So you get not just a buildup of fluid, you actually get tremendous cellular damage, and the ultimate outcome is prolonged and profound inflammation and hypoxia. And there's where the skin damage comes from, is the inflammation and hypoxia, which is usually present in these kind of individuals over decades rather than years. And so the buildup of this slow, insidious trauma usually means that for many people, by the time they've had years and years of swelling, pigmentation, skin changes, a wound ultimately comes almost inevitable because the wound is actually developing from the inside out.
Yeah, so it's not just the swelling, which is one of the common signs of the edema, but there's also other skin changes. You were saying like hyperpigmentation, that
Yeah.
staining.
Yes, that's right. So we call it hemosiderin staining. The thing
Yeah,
about that is the hemosiderin staining is ultimately the release of iron into the skin. So another way to think about that is iron loading. And that is very abnormal. And that's what ends up causing tremendous inflammation within the skin.
yeah,
And then you get the leakage. You see, it's all happening because you're leaking fluid, you're leaking red blood cells, white blood cells, you're leaking components like fibrin, which are involved in your blood clotting cascade. So all of these cellular ingredients in the end cause ultimately what will be changes, which we see in their end stages, inflammatory and also hypoxic inducing.
yes. That inflammation, I find sometimes people mistaken it for cellulitis, but
Oh, ultimately true. If you've got swelling there long enough, and it's certainly under a pressure load, these inflammatory changes do become very physically apparent. It may be associated with the leaking of watery drops of fluid from the skin. We call lymphoria. But without that weeping of fluid, you still tend to find that you get large surface areas of the lower limb where it becomes very reddened. It can become very itchy and uncomfortable, very heavy, very achy. But it is not associated with a cellulitic infection as such. The hard part is how do you differentiate between the red leg because of the inflammatory changes, because you're holding fluid in the limb, to then the cellulitic one, which the main difference between the red leg and the cellulitic leg is that the cellulitic leg compromises the host significantly. It's an infection which actually has an overall systemic compromise. These people are very, very unwell. They're in tremendous pain. They're running very high temperatures. Cellulitis is usually on one limb. It doesn't normally occur on both at the same time. Whereas when people do have these vascular venous oedema orientated forms of buildup of pressure. Often it's to both limbs. It doesn't have to be, but red legs, it's not uncommon to be both lower limbs that are involved.
Yeah, so maybe one difference is perhaps whether it's unilateral, which could
Yes, or bilateral, yeah.
be itis, or if it's in both legs, it could likely be edema or venous edema. And great. Then, and also I see a lot of patients in the community with calcium channel blockers. They were talking about
Yes, yeah,
antihypertensive, so amlodipine, one of the biggest
yeah,
so fluid lower leg,
yeah.
using that in the
And you see it often within 3 to 4 weeks of commencing these medications is when people will start to find that their feet and their ankles are starting to become a bit swollen. So it happens not that long after commencing some of these medications.
Yeah, that's right. And then sometimes just cutting it down or replacing it with a different medication can,
That's right. That's right. And just changing maybe the mix of having a calcium channel blocker, which is combined with an ACE inhibitor, for instance, might make that a bit better.
yeah.
It's interesting talking about medication. People think, well, if only I took a fluid tablet, that might make the swelling in my legs better. But if we go back to the bath analogy for a little,
Mm.
we know that your diuretics mainly turn the tap down. They don't really do a lot for the plug hole end. So if your etiology is actually the plug hole not draining, then you might find that your Lasix is turning the tap down. But if the tap is still running, even though it's slowly, but the bath plug hole can't drain, you're still going to find that you've got fluid running over the edge of the bath. You still have edema. So your diuretics don't do much for the plug hole, but they will help you turn down the tap. So often diuretics for many people on their own, maybe for some okay if it was a tap-related issue, but if people are finding they're on diuretics and their edema is not really being resolved, then it is a little bit of a clue as to, oh, maybe your kind of edema is related to something else.
Yes, I need you to explain that to our doctors because we see
Yes, we do. We do.
options,
A lot of people aren't aware.
yeah, for edema, just long-term ongoing at increasing doses, but sometimes it just puts them at risk of hypovolemia more than anything, isn't it?
Yeah, and then a tremendous change to their quality of life because they're always looking for toilets. They're always having to spend the first 2 hours every day, having to pass water. And terrible when you're wanting to try and get out to pay a phone bill or do your shopping. And so one of the first things people do is they stop taking those medications or they stop drinking.
Mm.
And then those activities, they have their own problems when those behaviors are manifested then.
Yeah, great. So then do we address the underlying problem, the plug hole, as you were talking about, in terms of getting the management of this
Mm.
role?
The thing that's interesting is really over all of these years when we talk about people with wounds, we often talk about if only we could get for Uncle Reg's wound the right dressing or we could use the right medication. We live so often in the hope of doing something constructive, but because so much of wound care and other forms of health may not necessarily be always science driven, often acting in hope repeatedly ends up causing disappointment. And so I'm very much of the idea is that we stop looking for silver bullets and start looking for ways of measuring the effect of the things that we do so that you can measure the size of a wound. You can talk about the percentage of the colors in a wound, the amount of exudate. We can, for limbs, we can start doing some very basic things by just having a tape measure and begin to measure them. I talk to people about drawing 3 dots on a leg. Draw a dot in the middle of the top of the dorsum of your foot. Draw a dot in the front part of your gaiter and then again in your calf. And then with a tape measure, measure those circumferences in centimeters. People like to use words of pitting edema or non-pitting edema. Now, these things are great, but they'll mean more to a lymphedema therapist than most of the rest of us. But why rely on words when you can be doing something with a measurement and numbers, and that is then easy and repeatable and sustainable? And really what we're going to be doing for somebody's lower limb edema is something as they very first present, do your 3 dots, do where these measurements are in centimeters, and then whatever we do for them there on in, let's regularly and repeatedly remeasure. Because then I'd love us to be able to say, you go back to the team you're working with, you go back to, where it may be the medical officer that you're wanting to help with this diagnostic idea of where are we at and why are we here. But present the numbers because we can say, hey, every week we've had Uncle Reg come in, every week we've done these 3 dots and the numbers, and we're not really seeing them changing much. He's still got a heavy limb. He still can't get his shoes on. He's, taking his diuretics, but not making that much of a difference. And this is what the numbers are saying.
Mhm.
So if we can be doing something like that on a regular basis, it means that you then have this ongoing form of assessment that when you start a therapy, you can then say, is this doing the job I want it to do? How can I determine the outcome is being achieved? The closest thing that we have for people with swollen legs within community practice, the closest thing to a silver bullet is compression. So we can talk about that in a second, and there are different kinds of compression. But if that's going to be the closest thing to a silver bullet at trying to get rid of lower limb edema, how do you know whether it's working? And once more, you need your numbers to guide you and tell you. And also you need it for your patient's sake too, because sometimes it's really hard to get people to buy into wearing something hot around their leg, or have something which is hard to get on and hard to get off. So how do you get them engaged? And usually it's by having them involved in the assessment process at the very beginning. And you say, hey, Uncle Reg, today these are your numbers. If we just try these interventions, let's redo your numbers and let them see what's going on. People actually are amazed. They become interested over time and say, what are my numbers today? How are we going? What did we do? And that can be very motivating as they get more and more feedback, but it needs to be with words or terms or numbers that they can relate to.
Right. And would you do those 3 dots at the same time of the day or different times of day, morning?
I don't think it matters that much. It's just that when you then come to remeasure, it's nice to keep that then consistent.
Mm.
For me, my preference is to try and do it as close to the beginning of the day as you can, if possible. But always with measurements, you seek to have consistency.
Yeah.
So it may well be that the time of day, or it may be the person doing it. You want to reduce as many of your variables as you can.
Yeah, because my patients usually tell me that it's better at the start of the day after they've been lying down overnight, having a good sleep.
Yeah, that's true. That's when
Yeah.
it will be. But it's actually for some people very helpful to do measurements more than once during a day.
Mm.
There might be some people who find and to clinicians too, that you do your measurement at the start of the day when you expect it to be smallest. But then what is it like at lunchtime? What is it like at dinner time? And if there's big changes in these measurements as we've gone to lunchtime and then dinner time,
Yeah.
how come? Why are these changes so vast? Why are they as big as they are? And maybe our compression or whatever our intervention is not really being that effective.
Mm.
So to be doing measurements initially a number of times a day might be helpful as we begin to understand, are we doing what we want to do? Are we getting the result we're after?
Yeah, I find some patients, they find the compression therapy helpful because by the end of the day, normally without it, they would be very achy and swollen. And
Yes.
but with the compression, they take it off and it's not so swollen anymore. So
That's right.
as
And so many people will tell you that the comfort they experience when they've got compression on board, when people have lived with the aching of the pressure build up in the leg, but also the aching again comes back to the inflammation. And what causes tremendous aching or discomfort is the hypoxia associated with the edema. So if you can actually start to remove that inflammatory burden of fluid, you actually make more room in the bath for the capillary end to deliver nutrients back into it. And as more nutrients come into the bath, the hypoxia subsides. And that allows a lot of that pain and discomfort to then dissipate away. So there's a lot to be said for having compression on board, and people invariably will say when its compression has been done well, that they are more comfortable with it on than with it off.
Yeah, and just before we go into the compression therapy, I find those symptoms of those leaky legs often cause that skin breakdown and
Oh yeah, that makes things terrible too.
yeah, where it will start with a skin opening or a
Mm,
skin tear, and it just becomes
mm.
chronic because it's non-healing or very hard to heal.
That's right. And any wound will not heal if you have an inflammatory and hypoxic environment. So a swollen limb is an invitation for very hard to heal wound repair. Absolutely. And the other thing you mentioned then, Lucy, is important too, because some of our very early signs of the integumentary system being compromised by edema is when they're getting their eczema or their irritation. They're getting the buildup of dry, crusty scale, and it's always itchy and sore. And if it becomes a bit raw, these are early warning signs to say that we actually do need help. And a lot of people will buzz off and start to use topical steroids and things, which do have a place and a role, absolutely, but probably should be for shorter time frames rather than long ones. And it's okay to be dealing with the anti-inflammatory agents, but ultimately you've got to deal with the cause. And that for many of these individuals is you've got to get rid of the edema. And then we can reduce then the amount and frequency and dosage of their steroid or anti-inflammatory and hopefully then wean them off that.
So if someone's got venous eczema and the itchy red legs, then it's not solely relying on topical corticosteroids, but
yeah,
the underlying condition and
exactly.
compression.
Yeah, you've got it.
Great. So can you tell us a bit about compression therapy and what are the different types and when is it appropriate to use which one?
Yeah. Ultimately, the role of compression, and you'll see this with one or two of the slides that you may show later on. The role of compression is to turn down the tap at one end, push more fluid through the plug hole at the other. If you can take that lymphedema burden held within the bath away, you reduce inflammation. And as you take that inflammatory volume of fluid away, you make more space in the bath to deliver rich, nutrient oxygenated blood. So you increase arterial perfusion. So these are the big four pluses of compression. Turn the tap down, better drainage down the plug hole, less inflammation, more oxygen. So that's why we love the idea of compression. Basically, what's the best compression to use? Ultimately, what the patient's going to wear. So that's the big deal. But in my mind, I have two phases in my head that I use. One is if you're seeing leakage of lymphoria or watery deposits just beading up and then running down the leg, I need to quite urgently help somebody reduce the pressures in that leg. If somebody has a swollen leg and they have a wound, then I once more realize that they need an intervention, which is almost like a rescue approach. So in my head, the management phase of dealing with lymphoria or wounds and edema, my preference and that of other authors who people will read is to say, let's be using bandaging systems, whether they be the commercial multi-layered ones or they be a multi-layered systems that people design themselves in their own units and facilities. But generally speaking, in my head, bandaging is what I will use for the intervention phase, and hosiery, wraps, and intermittent pneumatic compression devices will be used for the maintenance phase of it. Now, having said that, that's just my own bias, my own preference, is I like to bandage to deal with things urgently and then maintenance-wise use those other devices to keep them in that space. But that is not set in stone by any means. I've known many, many people who have used wrap systems from the very beginning, and they have used that because they could modify their tensions themselves. If these wrapping systems allow people some degree of control where they themselves, family members, neighbors, the nurse, can actually help them regularly readjust as they push fluid out of the limb, they can readjust the tensions in their wraps. And that allows them to have great degree of control and persistence in pushing fluid out of their leg, even in the presence of lymphoria and even in the presence of wounds. And the beauty of wraps is that they can be washed and reused many, many times. So people who've been successful in not using bandages but using wraps for these scenarios have been those who've usually had 2 or 3 sets, and they've always got 1 set in the wash, 1 set drying, 1 set on. So there's a bit of expense there, bit of work there, but it can be done very successfully. But in my head, I always come with the idea of what's the intervention phase and then what's the maintenance phase.
Yeah.
And those two things just look a little bit different in my head anyway.
Yeah. So if they've got edema, you'd want to reduce it with either wraps or bandages.
That's my preference, yeah.
At a higher pressure, which is say like 30 to 40 millimeters mercury, or depending on their diagnosis and what they can tolerate.
Yeah, that's right. And that you said something then too, which I do find a lot of clinicians get a little bit hung up about, and that we know the literature talks about the strength of your sub-bandage pressure. Whether it be 20 to 30 being the lighter to more moderate level, 40 to 60 being the moderate to heavy end. Most of us actually never know how much sub-bandage pressure that we're actually applying. You might have a guide from a bandage if it changes, say, a oval to a circle or a rectangle to a square. Some of these types of bandages give you a bit of a guide. Some of our wrapping systems can give a bit of a guide as well. But ultimately, I actually these days don't get people to get that hung up on those numbers. What I'm interested is two things. First of all, is it tolerated by the patient so they can continue and will endure with it? And then secondly, you've done your 3 dots already in your assessment. So come back to your 3 dots. And if your compression is doing its job, then you should find your circumferential measurements are coming down. And as your circumferential measurements come down, then ultimately you will reach a plateau where your limb volume is now consistent. If they have a wound, we should find that the level of exudate is also coming down as limb circumference comes down. Or if they had lymphorrhea, then that should have dissipated also as the circumference has come down. So a much easier thing to measure than the sub-bandage pressure of 20 or 30 or 40 millimeters of mercury is to actually again revisit your circumferences and do it frequently, just to see whether your intervention is having the desired outcome. So if it's tolerated by the patient and your circumferences are coming down, then that's usually a successful system.
Yes, I guess it can vary between individuals and their leg shapes and the type of the application, all of that. And yeah, I find I had one of my patients, we tried the bandaging with 3 layers or 2 layers, sorry, and it was according to the manufacturer's instructions, but it was giving him blisters on his legs.
Yes, yeah.
Skin breakdown and more wounds. He had a chronic ulcer by that time already. So we were trying to reduce edema and control the leg ulcer, improve it. But he wasn't tolerating the bandaging. But then we switched to wraps, and that just made a huge difference. You could see every few days, every week, it was improving and less risk of that damage to the skin. It does depend on the
And isn't it nice to have a variety of tools? Because really that's what we're talking about. All these things, they're tools. And it's really your patient who helps you define what the job is. So when you do your assessment and you've made your agreement or compact or contract with your Uncle Reg, it's between you and your Uncle Reg patient to kind of say, well, what are our goals? What are the endpoints? How are we going to get there? How do we know we're making the difference we want to make? And then whatever tool you use to do the job may well vary from one person to another, from one clinician to another, from the resources you have in one facility to another. So I don't think we should ever, with any dressing or with any compression device, ever get hung up on one thing being the thing to use for everybody all the time, because it never will be. Between you and your Uncle Reg, your patient, let that define what the job is, and then the job tells you what tool you need. And there may well be more than one tool to choose from.
Yeah, perfect. And can you tell us a success story of a Uncle Reg, perhaps, that in your
Yeah. Look, I use the term Uncle Reg when I'm teaching, and it could be a female as well, It's just one way of describing, oh, this is that group I'm talking about. Uncle Reg could be anyone, any age, any sex. Look, because I work in a lymphedema unit within the rehab hospital, I get to see people who come in from all over New South Wales. So we are the largest private provider of lymphedema services within this state. So they come from all over New South Wales. And probably the thing that I find of greatest value is not one individual, but a very common story amongst many. It is not uncommon as people become older, as they become heavier, as they are on multiple medications and some degree of polypharmacy. And of late, as with the whole cost of living crisis, we have so many particularly disadvantaged, financially disadvantaged and age vulnerable people experiencing malnutrition. And malnutrition in Australia is a horrendously disappointing driver of lower limb edema. I mean, we shouldn't be having that in this country, but we are. So for all of these reasons, we see people who occasionally can get the funding to come our way, often through NDIS or DVA, or sometimes a private health fund, sometimes just family members pitching in and helping out. And we are meeting people who, with everything they've had to endure, have been housebound for months or even years. And we will have them with us for 3 weeks, 4 weeks, on rare occasions up to 6 weeks. But if we can make a difference, we will see that we can make a difference quite quickly. And we can't help everybody by any means. But those that we can, you tend to see things starting to turn around quite quickly. And it's a whole team approach. It's the medical team, it's the dietitians, it's the allied health, it's the lymphedema therapists, it's the nursing staff. And with everybody on board, this whole Woundiverse idea to surround somebody and encapsulate them and help them. But you know, when they leave you, it's a great thing to feel that they've got a set of tools that they are now able to be self-sufficient and can care for themselves. And then the next thing you know, Lucy, is you get an email or you get a phone call. And Uncle Red says, for the first time in 2 years, I've just been to the movies. You know, I just did something wonderful, Lucy. I went down for the first time in 6 months and I paid my electricity bill in person at the post office. You know, this is everyday stuff. We never think about it.
Yeah.
You have multiple people who've been in these self-isolated, sometimes not through choice, but to be very isolated environments, who are now having the opportunity to re-engage in society. That's something I really love. Their quality of life is turned around, that once more they're engaged in the society that you and I may take for granted.
So this condition can really be debilitating for some and
Oh,
affect
very much.
life, well-being, and something as simple as going to the movies or seeing
Yeah,
friends.
yeah.
It
You
really
can't do any of
feels.
that.
Yeah,
Yeah, yeah. I
yeah.
mean, I had one guy who was like me, a granddad like me. I get the privilege of regularly picking my grandkids up from school. And so for my Uncle Reg to tell me that for the first time in nearly 2 years,
Mm.
he's been and picked his grandkids up from school, I could almost feel the joy and the emotion of
Mm.
him being able to do that. And what a wonderful, joyous experience. So
Mm.
I thought, well, yeah, that was healthcare at its best, that he had that quality of life back.
Yeah, that's the ultimate goal, isn't it? That
Yeah, yeah,
the patient
absolutely.
happier at the end of the day. Yeah,
Absolutely right.
wonderful. So in community pharmacy, we have a lot of people come through asking for help with their lower leg swelling, or they've been referred by their GP to have
Mm,
compression stockings. And we have a range of stockings available to us
yeah.
in a community setting. Can you tell us a bit about the compression stockings and what their role they play? You mentioned that it has a role in maintenance and
Yeah, from a maintenance phase. And look, I think all of us know, Lucy, people who have experienced limb swelling, who've all been told to get stockings or have been to a pharmacist or some supplier of hosiery. And many of us are going to know people who've bought stockings and they've found an excellent place, usually in a drawer somewhere, which rarely gets opened.
Mhm.
And so they've had them fitted, applied once, but then they've gone into the black hole of the drawer, never to be seen again. Or maybe just to be worn once while you go back to see a GP, just so you can see that you have got it on, but otherwise you're not really wearing it. So there is this tremendous love idea of prescribing and the hate idea of many people think too hard to get on, too hard to get off, can't do it on my own, doesn't really seem to be the right fit, although it seemed to be fine in the pharmacy, but now at home the damn thing is shrunk or it seems to be smaller.
Mhm.
Maybe I haven't washed it right or didn't really understand how I should wash it. And oh, look, the dramas around hosiery, there's so many stories as to why it really sucked or I couldn't really do it. Or I live up in northern Queensland and it's just too damn hot and oh God, can't wear those things,
Yeah.
you know. Yeah, you know, so many really people have the most brilliant reasons not to wear them. Um, I do honestly think one of the problems has been when measuring people up for hosiery has been done poorly and done at the wrong time.
Mm.
So really you want somebody down to the lowest circumferential measurements that they can comfortably tolerate. And then that's when you should be measuring for hosiery that then really keeps them at that limb volume. So when you measure needs to be done in really the right time in their cycle as they've emerged from intervention to maintenance, because maintenance is that it's maintaining that limb volume and size and shape that you've attained. And I do find that sometimes in order to push people through the system a bit faster, sometimes people would prescribe things which might just be that little bit firmer, that little bit tighter, in order to think that'll finish them off. That'll just take the last of that edema away. And that can be when people are at home on their own, less self-sufficient. Don't have the expertise that people back in the lymphedema unit or back at the pharmacy had. So that can be awkward. The great thing that is now available to all of us is donning and doffing aids have just developed extraordinarily and are so much better than they were 8 and 10 years ago. So good donning and doffing aids needs to be very much part of the education around hosiery as well. I have to declare a bias, Lucy.
Yeah.
I'm very biased towards flat net hosiery, only because I think of where I work and the cohort of people that I see. But because there are such good donning and doffing devices now, flat knit stockings which have no elasticity to them, they're actually far more comfortable for people to wear. Once these things are on and off, but once they're on, they're much more comfortable because you're getting high peaks of pressure when a limb is in motion. Whereas when a limb is at rest, the pressures are much lower. Whereas with elasticated hosiery, they're compressing and squashing you every moment of every day, all of the time. So it's like you're getting no rest.
Mm.
But also you're getting much better pressure variations on the flat knit where there is low level at rest, but then much higher peaks of pressure when the muscle is meeting the resistance of the stocking. So I think the physical and physiologic effect of flat knit, I think, is better than the elastic ones. And I think ultimately the comfort is, and just between you and me, so we can't tell anyone else, but I've had many people who wear flat knit hosiery and they're in northern Western Australia, Northern Territory, Northern Queensland, have to deal with hot, humid, really difficult conditions. And the flat knit hosiery copes best when people walk around all day in their hosiery and they've got their bottles full of water with their sprayers, and then they just spray the water mist over their hosiery and then let the hosiery evaporate, and that helps them cope with the very hot conditions better.
All right. Cooling.
But yeah, so it's a patient-related story of how they cool their legs down. So whereas doing that with the elasticized hosiery may in time maybe be a little bit problematic if we get shrinkage of the hosiery. It doesn't seem to be as big a deal with the flat knit as it does with the circular knit. But
Yeah.
then also now there's a third branch to hosiery, and that is the multi-component hosiery, where you've got two layers. You've got a liner, and then you've got another layer which can go over the top and have a zipper to do it up. I have to confess that there are a number of people in their 90s that I look after who love those two-layered ones, because the first layer is like putting on a flight sock. It's a little bit slippery, so it's easy to get on and off. And they put the brown layer over the top of that and do the zipper up, and it just locks it all in. And they find they can cope with that very well. But many of these dear oldies can actually get them on and off themselves. If that is a bit challenging, then they can at least get the white one on and get a neighbour or a family member or someone to do their brown layer for them. And they can take the brown layer off at night if they want to have a rest, and they can leave the white layer on if they wish to do that.
Yeah.
The multi-component hosiery, flat and circular knit are all options. Circular knit by far is the most commonly spoken about, the most accessible, the most commonly supplied. And I don't want to dish them. They're really useful. They can be the ideal tool for maintenance, but it's just nice to know that there's a range of tools there again.
Yeah, great. That's interesting with the flat knits, because I realized that they had a higher working pressure, you were saying.
Yes,
So
higher working pressure, lower resting pressure.
less when they're resting.
Yeah.
Yeah, so the only other barrier that I can think of is that it's the cost factor, and those
Yeah.
flat knits often are a lot more expensive, in the hundreds of dollars, compared to some of the circular regular.
That's true. That is true. I mean, thankfully they're very robust and they have a good life cycle. But I'd have to say that, and again, this is my own experience. I come with a little bit of bias, perhaps because of that. But we have found that with our lymphedema patients that we regularly would see at the Mount Wilga Hospital, people are more likely to be wearing and utilizing their flat knits long term than necessarily the circular knit. And I think it's because they get this period of rest when pressures are lower. And so invariably they do say flat knit are more comfortable than circular knit. And it is more expensive to buy initially, you're dead set right. So sometimes they're going to be like Enable here in New South Wales, and other states have schemes where there may be some subsidising for this. Particularly anyone who has a diagnosis of lymphedema can end up getting some of these things subsidised. But I kind of think really the most expensive tools really are the ones which are bought but never used.
Yes, that's
And
right.
I think ultimately to me, they're more expensive than a tool which I did buy, I spent more money on it, but I'm actually utilizing it and I'm getting a benefit from it.
Yeah, and you mentioned before about the pressure and not getting too hung up about it, because one of the biggest issues I find when people come in wanting compression, they've said they've used it before, and I ask them about, what were they using, which type, what pressure, and they showed me something with the 30 to 40 millimeters that I couldn't even get on for them, let alone themselves, with often issues
Exactly right.
with mobility or bending, reaching their toes, and that. So even getting them something that's 20 millimeters that they able to get on a lot easier. And I find with the open toes, they can use a Donning's plastic slip that they can pull over with a little bit more ease. Or a frame.
Indeed.
Yeah, they are able to get on at least without breaking their backs.
That's right. And there's nothing to stop them in time titrating up to stronger levels of compression if they're needed. But once more, it's the idea of what is your data telling you? What are your numbers saying? So it's a matter of how they feel, what they can use, their level of comfort, but also what do your circumferential measurements talk about and what difference are we making? Because some people may well find if they can regularly apply a lower class setting, but they're religious with it, they can do it, that allows them to mobilize. It may well be the sheer fact that they've got this on and they're mobilizing more than they were, means they're getting then a calf muscle pumping exiting of lymphatic fluid out of their limb. Sometimes that's enough to bring their limb volume down. But so, yeah, always I try and have some form of objective marker to say, well, it's great we've made a choice, is our plan. And when we come to evaluate, what have we got that helps us objectively say, this is better, or we've made no difference at all.
And is any contraindications to compression?
Yeah, there are some red flags. I suppose there's always going to be one of the red flags. We do talk about physiological stuff, which we'll do in a minute, but one of the red flags is going to be somebody who has the capacity to understand what we're doing, why we're doing it, and then someone who can oversee that what they're doing is safe practice when they're not with you, they're in their own home or wherever they might be. With compression, there is always the risk that if it's not done well, that there's been a minimal positive effect or potential harm. So I just like the idea, is there somebody around who knows what we're doing and why we're doing it and how we're doing it? Because if somebody you do not have confidence in is part of that narrative, then to me that is a red flag. If you can't be an active participant knowing and understanding, then maybe I'm wary of that situation. I work at the rehab hospital with people who have loss of sensation through spinal cord injury or brain injury. So that may be in some settings, if there is no capacity for integumentary and neurogenic feedback, if you can't feel what's going on, that could be a bit of a red flag for you. If somebody has actually had a bypass graft so that they're now supplying blood around an obstruction in an artery, but if that bypass is running in the adipose layer in the bottom part of the skin, so it's above the muscle fascial plane, then that's another one that you wouldn't compress. So I'm always aware if somebody's had a bypass of the lower limb, an artery bypass, is that safe to squash or not? So are you mentally up for the challenge? Can you feel it being applied? Have you had vascular intervention? Another one is heart failure. We used to think that you would never compress somebody in heart failure, but the guidelines now are that you compress people who are in heart failure except for those who remain symptomatic. In other words, they call them unstable heart failure. So they're receiving care, they're receiving intervention, but they remain breathless upon exertion and worse still, breathless at rest. So those people we wouldn't compress. And then the one that everyone thinks about is, is there enough arterial flow coming down to the limb? So I always like to start with the idea is, can you feel a pulse? Can you do your capillary refill? Can you do what's called the Berger's test, which is usually a sign of late vascular disease, but it is where you elevate the limb for 60 seconds to see whether the foot becomes pale or a colder temperature. You then put the foot to then hang down. So if somebody's on an examination table in a bed, are they pale on examination? Do they go rubor or red when the leg hangs down? Pallor and rubor is known as a positive Berger's sign. So if you can not feel a pulse, do a capillary refill. You don't want your refill to be longer than 3 or 4 seconds. It should be less than that. Is there a positive Berger's test with pallor and rubor? And there's another little nifty test that you can do in the pharmacy. And if you've got access to a pulse oximeter, if you can get somebody once more at rest on a couch or a bed, do a reference reading with your pulse oximeter on an index finger, see what they normally sit at. It could be 96, 97. And then what's it like on their great or second toe, and see what that is like when their leg is down. Is it similar to their finger? It ideally should be very much the same. Maybe a normal circulation like yours, Lucy. Yours might be higher at the foot than it is at the finger. But then once you've had time to have this person at rest, stabilized, and you've done these reference measurements, there's some excellent work done where the vascular people have said that if you were now to raise that leg by 30 centimeters, so there's 30 centimeters between the heel and the bed or the heel and the examination table, If at that height, your oxygen sats now start to drop away, by the time they drop 2 or 3 percentage points, that may be an indication that there is a reduced arterial flow. In my head, I'm looking for a jigsaw puzzle, and these are all pieces of that jigsaw puzzle. So can I feel the pulse? What's the capillary refill? Is there a positive Berger's sign? What's my pulse oximeter saying? And if I'm not happy with those 4 things, I'm then going to go to the GP and say, hey, doc, these are the 4 things that I've found. I reckon there's other jigsaw puzzles that are needed in this particular story. How do you feel about getting a Doppler study done so that we can do a pressure test, which is called an ankle brachial pressure index? And they may also then produce some words around the waveforms. In other words, how elastic is the artery? Because you want the pressure test to tell you as to how much blood's coming down the leg compared to the arm, but then you also want to know if the arteries are healthy. A healthy artery is very elastic, whereas if the artery is like a concrete pipe, it's going to have a different sound. So, and then you can go on all of the way to then do CT angiograms. You could be doing IV contrast angiograms and MRIs. All of this, there's a whole bunch of stuff you can do, but we just start very basic in community care with the things that you can do right now. And what you can do right now is the pulse, the capillary refill, your Berger's test, and the pulse oximeter. And there's your beginning point. Because if you're unhappy with any of those, am I going to squash your leg? Probably not.
There's also these simple ABPI tests that you can use in.
Well, that's right. You've got automated ABPI tests that you can do if you've got access to them. Yes.
And then, so if you've got arterial insufficiency, that means there's lack of oxygen going to the leg.
Yeah, correct.
Maybe a risk of issues with compression.
Yeah, and so that's probably our biggest reason for having a red flag would be arterial insufficiency.
Yeah, so some people with diabetes perhaps, or...
Oh yeah, yeah, chronic kidney disease is another group. Diabetes is a big group. Anyone with a family history of this, ischemic heart disease is another correlation as well. So yeah, in fact, anyone who says, oh, are you on high blood pressure tablets? Yes. Well, then their blood pressure tablets could be giving them their edema, but they're on blood pressure tablets because they've got a monophasic waveform, for instance, and their artery is a concrete pipe rather than an elastic one. So yeah, all of these things overlap one with the other.
Yeah. And can you tell me what zinc paste bandages do? And
yeah, I'm a bit of a fan. So I'd have to say I'm a bit of a fan of these. You know, most of the body's zinc is stored within the keratinocytes in the basement membrane of skin. So your integumentary system holds a huge amount of zinc. And the keratinocytes, which make up really the bricks of your epidermis. So keratinocytes and other things we call, so altogether they're a group called epithelial cells, but most of the epithelial cells are keratinocytes. They're the house bricks, and then your lipids and fatty acids are the mortar that goes around the house bricks. When you've got really red legs, as we've talked about already, where it's inflammatory based, if you've got the iron loading or you've just got retained lymph in skin and your keratinocytes become really inflamed, when that happens, they become swollen and the mortar around the bricks becomes degraded. And the major job that your epidermis has is to be a wonderful waterproofing shield where it controls the amount of water that's in the bath underneath so that, you know, you do not lose through evaporation too quickly the water in the bath underneath. So your epidermis is meant to help you control that. But when your keratinocytes become inflamed and swollen and you lose that mortar, huge amounts of water vapor are escaping. And that causes keratinocytes to become itchy. It becomes then, with you lose your mortar, it is very prone to excoriation. It can even then lead on to maceration as all of this water and vapor is being lost. But one of the things that is great about zinc is that zinc, when it's reabsorbed back into the keratinocytes, is it stabilizes their cell membrane. And in stabilizing their cell membrane, they become less inflamed, less leaky, and it allows the restoration of the mortar around the bricks. And people who've got really red and swollen skin will tell you that when zinc oxide bandages or tubes go on, they say just how soothing they are. And the reason that you need to use it as a bandage or a tube is because they're a zinc oxide at 20%, whereas pseudocrim and a lot of these other forms of zinc are at 10%. So there is a dosage difference. But the other thing about doing it in the bandage or the tube form is that you release the zinc very slowly over hours or even days. So you have a higher dosage level, but a very slow release. And usually after 1, 2, or 3 applications, you tend to find that a large amount of that inflammatory stimulus to the keratinocytes is starting to come down and work its way down. So we don't tend to use these products in any one patient for very long. It's just all part of a strategy where here is another tool that may be able to help you bring inflammation down. And then once that's occurred, then you would stop using it and use something else like a good quality moisturizer.
It could be helpful in someone with venous eczema, perhaps.
Great for venous eczema, brilliant for that. It can actually be very helpful in people who experience psoriasis as well. You know, in some instances, people may want to have their short-term, very directed steroid hit. But as you then wean that off, then here is another great substitute to have as your next step in that pathway. And you've got some people that get very red legs where the massive surface areas of their leg, there's such a big surface area involved in the swelling and the irritation that really this is where a bandage or a sock can be really helpful to cover such a big surface area. But yeah, there's nothing as annoying or irritating as the venous eczema, which then often through scratching and itching causes secondary trauma.
Right, like a lot of ulcers or infections.
Yeah, because when you've got these venous conditions, like we said earlier, they are really an inflammatory problem happening for a long, long time. And for many of those folks who get venous leg ulcers, they're a wound which has happened over a lengthy period and have occurred from the inside out. And it just takes a little event like a scratch or a knock or a bump, and what has been an inflammatory process for a lengthy period now becomes a wound.
Yeah. Okay. Wonderful. So you can also use compression bandage over the zinc paste.
Yes, you can. Yes, and you've nailed me again. You've read my brain. Yes, that is my bias and preference, is that I would use these with bandaging over the top. And once you've entered that maintenance phase, you shouldn't need to be using those products.
Then you can go on stockings or
Yeah.
to be able to wear long term. And do these people usually have to wear these compression hosiery for life?
Yes, look, I'm going to bring you all of the way back to the beginning now and ask you to say, well, really, the best answer to it is, have you got a problem where one, it's been diagnosed as a tap or a plug problem or a combination of the two? If that problem can in some way be resolved, then maybe you don't have to wear them forever. But for a lot of people, once they figure out the nature of what has caused their edema, for so many people, the issue is not a resolvable one. And so that means they're going to have tap or plug problems for the rest of their life. And if that's the case, compression is part of that story for the rest of their life. So for many, that will be the case, that compression is there forever, but not necessarily for everybody all the time. You just need to know, why is it there? Why is this swelling there? And once we've got that figured out, then we have a better answer to, do I wear these compression stockings forever or not?
So if someone has had a history of DVT,
Yeah,
can they have also a higher risk of edema?
they do very much.
So
Yeah. In fact, you'll find that that's one of the most common reasons for turning the tap up high. So there is a very significant tap problem. When you resolve that DVT, it now depends upon, well, what damage did that cause? Some people may get lucky and not require compression for the rest of their life. But if they've had what's called post-thrombotic syndrome, And we now realize that they have a whole sequence of damaged valves, that they have a broken endothelium, and they've got a leaking venous wall. Then yeah, they may well require long-term or the rest of their life compression. But yeah, DVT is such a common way of turning your tap up super high, and before you know it, your bath is overflowing.
Yeah, thank you. And this is the last myth I'm going to debunk on. So TED stockings, they're
Yeah.
not the same as compression stockings, are they?
No. And you know what's fabulous is to actually spend a little bit of time, do a bit of a survey and ask your colleagues, what does a TED stocking stand for? What does TED mean? And I am not surprised anymore, but as I do my teaching around Australia, I've learned that the majority of people, when you say a TED stocking, what does TED stand for? And most people can't tell you. So it stands for thromboembolic deterrent stock. In other words, how not to get a thrombus, how not to get a DVT. Now, I must say the whole idea, Lucy, is a pretty old one. It goes back decades now of saying how when somebody's spending time in bed, and usually lengthy periods of time in bed. So it often comes from the hospital environment, and particularly with acute or surgical wounds. How can you have somebody unwell enough to be in bed repeatedly for long periods of time? How can you make sure that in their veins, the venous flow didn't pool? Because if it was to become sluggish or stagnate, then the platelets may clump together and clot. So we've got much better now in the way of using anticoagulants. They've improved enormously these days. In the operating theatres, they're now using electrified calf muscle stimulators, and we're getting people up and mobilizing so much sooner than we ever used to. So one of my two things to share with you is, firstly, do we even need TED stockings anymore? They were an essential part of our armamentarium years ago, but maybe now we can see them as just one tool, but there are other tools now, and a TED's always for everybody all the time. They once used to be, but should they still be? That's just a thought.
Usually,
The other thing is TED stock. Go ahead.
sorry, are they usually used if you're lying in bed in hospital?
They're mainly used for when you're lying in bed, and that's the thing is people are by and large now not doing that nearly as much as they used to. But those who are, it was meant to give you a gradient of a higher pressure at the ankle and a lower pressure at the knee, and that would give you your venous and lymphatic return. But the pressures were never more than about 18 millimeters of mercury at the ankle, become a little bit less than when you're up around the knee. But the problem is, Lucy, when you're sitting in a chair, the pressure at your gaiter area is around 45 millimeters of mercury. When I'm standing up, the pressure at the gaiter area is probably around 70 to 80 millimeters of mercury. So how does something which gives you 18 at the ankle push uphill against 45 when you're sitting down or 80 when you're standing up? The way that the TED stocking is physically designed and engaged is not intended to push fluid against gravity. It's meant to push fluid when you're in bed unimpeded by gravity to give you venous and lymphatic flow so you don't get stagnation in the vein. But it is meant to work in the absence of gravity. They are not an anti-gravity device, whereas other forms of hosiery, wraps, and bandages are your anti-gravity device.
Great. I'm so glad that you've clarified that, because we often get people being prescribed TED stockings and we tell them TED is for bed. So if you're walking and upright and mobile, then it's not going to be appropriate for you.
Yeah, absolutely right. So Ted and Teddy go together. What a great place. They can join each other in bed.
Yeah.
Yeah, very good.
Wonderful. Now, just to the last bit of advice, can you give us to allied health professionals considering becoming a wound care clinician or a compression therapist or lymphedema practitioner, for example? So what would your advice be?
Look, there are some great education providers around Oz, absolutely. first of all, show a bias again. I think one of the best ways of learning to get into the lymphedema space, and I'm really thrilled to see the numbers of pharmacists who are learning to become lymphedema therapists. I have to show a bias and a loyalty to the alert team at Macquarie Uni. They have a 9.5-week program where you can learn to become a lymphedema therapist. And again, it's across all professions. I know medical officers have done that, nurses, pharmacists, an excellent program that has happened there. I do run a bit of a module that works off that fundamental course where we talk about wound management for people with chronic edemas. So there is my bias. I do talk and present and work with the folks at Macquarie Uni, and their program I know firsthand. But I do know that they are not the only providers, and the Australian Lymphology Association is a very good group to get involved with, because they will give you contacts of people who are themselves great lymphedema therapists, and they'll also get you in touch with great other education providers within the lymphedema space. So the Australasian Lymphology Association is like our national body, as indeed we have one for wounds called Wounds Australia. So I think as peak and national bodies, they're worthwhile speaking to somebody there or looking at their websites, because there's a whole range of lymphedema education providers as there is wound education providers. I once more will show a bias by letting you know that I think one of the greatest providers of postgraduate education in wound care is Monash University. But once more, they're not alone. There are good online things that you can get involved in. There are face-to-face programs. I do one at the Australian College of Nursing, for instance. So yeah, there are some good providers around, but if need be, hit up Wounds Australia and hit up the Australian Lymphology Association, and you've got two really good national key bodies there who can take your inquiry and help you run further with it.
Yeah, wonderful. And I know that you've got a very active platform on social media, LinkedIn and Facebook, the Wound Guy of Gary Bay. And you also have a YouTube channel that
Yes, that's something that's started this year.
Yeah.
And it's again with the whole Woundiverse idea. It is meant to really be for a little bit of everyone, as this whole YouTube channel ultimately evolves over time. We're after a lot of different stories from a lot of different people, because it's all about ultimately saying, how do we look after our Uncle Reg's better? You know, there's around 600,000 people who get out of bed every day in Australia with a wound that doesn't seem to get better. Imagine that, 600,000 people whose life is dominated by a wound. So they need a heck of a lot of people to be on their team to help them fix that and have a better quality of life. So really, this is what the resources of our Facebook page, our LinkedIn, our website, but now also the YouTube channel is about, is how do we engage with as many people as we can to bring their skills, their ideas, their thoughts, their inspirations together, just so that ultimately all of us can come together as a bigger community to wrap our arms of love and care around people with wounds and hopefully make a difference.
Yeah, what I love about it is it's in layman's terms, and it's in terms that we can understand these.
Yeah.
Like wound is like the beach, or the wound is like a builder site. You know, it's really build that picture in our mind to consolidate what wound care is and those.
Yeah, absolutely. And I'm a very firm believer in having words or developing a language, not just around the patient that they understand, but just so that everybody that we communicate and work with do. You just want simple things which allow us to make sure we're on the same page and give us an idea that our goals then are easily realized as they are then understood as well.
Fantastic. Well, thank you so much for your generous time, Gary, and wealth of knowledge. I'm sure it's very valuable to all of us in the medical profession and in Australia-wide, as well as beyond. So I am going to share this very shortly, and all of your wonderful resources. And
Thank you, Lusi.
you also check out the Wound Guide website, social media, LinkedIn, Facebook. You'll find lots of great evidence-based articles and latest updates on wound care and education. So
Thank you, Lusi. Pleasure to be involved. Thank you so much.
wonderful. Thank you. Bye-bye.
Bye.